which we project on Zoom, which we're doing like today. And then before we had our second surge, we were actually doing in-person conferences, but doing them with small participant pools. So usually about 5 to 10 people in large rooms, safely spaced about 6 feet apart. And then in regards to our daily like recorded Zoom conferences, we actually have an active YouTube channel. And so as all my chiefs like to say, punch that like button and y'all can watch some high yield information, hopefully for everybody, if you find the CUIM channel. So without further ado, I'll go ahead and get started with our case. And the chief complaint for this case is going to be lower extremity pain and weakness. So this patient is coming in. I'm sorry, let me just pull up my screen. Perfect. All right. So this is a 39-year-old vet who was directly admitted today from the RAC clinic for left ankle pain and 5 weeks of inability to care for himself. So the story that he says is that he went to the ED 5 days ago, initially or 5 weeks ago for left knee and ankle pain that had been going on for 3 days, that he attributed to overcompensating because he was having a flare of his acute low back pain. At that time, he was given follow-up visit. He was seen in the RAC clinic. He was found to have some swelling of that pain, tolerate the meloxicam, so he was actually switched to a Tortolac. 2 weeks later, he actually presented to an outside hospital because of this lower extremity pain, left lower extremity pain. It was actually found to have a left lower extremity peroneal DVT, as well as some mildly elevated LFTs, and was sent out on a DOAC after he presented there with acute episode of shortness of breath. Of note, too, he actually had a negative CTPE. Today in the RAC clinic, he actually states that the pain has progressed in severity, where he's now having pain in his left hip, as well as now as his right knee, and is unable to walk. Because of this, he's actually been staying in bed. Of note, he does endorse some numbness on the top and bottom of his bilateral feet. And so kind of starting out with CJ, what are your thoughts right now about this case?
Yeah, I mean, it's a lot of information right off the bat to kind of go through. So I think kind of breaking it up into pieces would be the first thing I would kind of look at, and seeing how this seems to be a progressive polyarthritis kind of picture, as it seems to be maybe isolated to the joints more so than the entire leg. Although I'd probably kind of ask that to figure out, is it actually of the muscle that's painful for him versus the joints, would be, I think, an important distinction. And it's odd that he had this DVT and liver injury as well, which I don't think right now I have a great sense of what to make of that, but kind of keeping that in the background. And so with this kind of polyarthritis picture with swelling, I think first things to kind of rule out are like things like septic arthritis or anything that is more serious. It seems like he's still able to walk. Oh no, he's unable to walk now. So I think that's a concern, and getting a good physical exam to assess for like musculoskeletal related things, which at this point seems less likely given the rapid progression. So between the time course and the severity, kind of wondering if this is like an inflammatory polyarthritis, but I think right now I just need more information, past medical history, to figure out if he's got any background conditions that could be contributing to this. But yeah, I think the differential right now is pretty broad for me.
Yeah, no, that CJ, that's fantastic. That was a great approach to this case. This is, this is like, it's hard to kind of pinpoint exactly where it's going. Right now he's got, from what you can tell, it's kind of like his back and his legs are hurting. Now, is that muscle? Is that joint? That's kind of the thing that's hard to tell. So if you, and I'll kick this to Claire or Manny too. So if you guys wanted to figure out if this was muscle or joint issues, just going from the history, do you guys have any kind of questions that y'all would potentially ask? Claire, I'll give it to you first.
You mean muscle or joint pain, I assume you're talking about?
Yeah.
Yeah, I mean, I would be curious just to hear more about the pain, like exactly where it is. Is it around the joints? Is it like painful to move his, if is it painful to move his joints? Is it painful when he presses on his muscles? And I'm kind of curious more about this weakness. Like, is he just feeling weak because he's in pain? Or does he have like any kind of more like what sounds like neuro weakness? I would also just say, like, I always like to start out by thinking about the patient, and sort of, I think that helps frame things. And this is a 39-year-old man. Like, I don't have past medical history. That could certainly change things, but this just right off the bat seems pretty abnormal for a 39-year-old person, to have now be unable to care for themselves, is what I would say. And I agree with what CJ said. Like, kind of, I'm a little bit worried about like a general inflammatory process given the LFTs. And then like the DVT is interesting. I'm pretty inclined to, I certainly doesn't sound like the DVT can explain all of this. I'm sort of wondering whether he's got an inflammatory process and then the DVT is second to that. But yeah, like I said, I think kind of getting a sense of if the pain is in his joints or muscles, like if it sounds kind of more like a like autoimmune kind of joint pain, like worse in the morning, and then kind of getting a better sense of this weakness if it's secondary to pain or if we have another process going on there.
Yeah, great. That was fantastic. That was a very good approach, and I appreciate you taking the step back and like saying like, who is this patient, and is this sounds kind of odd for a 39-year-old patient to be complaining about muscle and joint pain, right? This is not somebody who we usually think about wear and tear like osteoarthritis. So great. No, I think that's a fantastic approach. And just like as a clarification, he does say, yeah, he does say he's got joint pain predominantly like in his knees and his uh, bilateral knees and then his left ankle, and he does feel like there's swelling there as well. And you actually kind of touched on something about like autoimmune or like autoimmune or inflammatory etiology for joint pain and talked about morning stiffness. What are you talking about exactly, Claire?
I mean, honestly, normally kind of use that to differentiate more like a autoimmune from an OA. And I don't really think this is OA. So I don't know how helpful it is in this case. And it sounds like he's probably not even using his joints anyways, but that's just kind of what I was thinking with that.
Yeah, no, that's great. And as just somebody who's like a budding rheumatologist, like being able to say like kind of the cutoff, we usually say like if somebody usually will say they have morning stiffness and it takes like if it's over 30 minutes, that kind of raises your suspicion for like an inflammatory etiology for this kind of joint pain. And then classically too, they say things like it gets better through the course of the day and it's worse first thing in the morning.
Hey, Corey.
Yeah.
Hey, it's Mark. Hey, one of the things I want to really highlight that CJ and Claire did is that when you're dealing with really undifferentiated cases, there's a lot of different ways to approach it. But one of the things I want to highlight is that they did two that I use really routinely. And one is sort of the anatomic approach. It's like, okay, what's the patient complaining of? What's in that area? So like, I think CJ really like nicely highlighted that. And along with that, like then I use like sort of the chapters of the textbook. So back in the old day when we still had like the 700-page Harrison textbook, is if I went through each chapter of this textbook, like what could be the rheumatologic cause, what could be the vascular cause or cardiovascular, and sort of starting to separate things out like that as you think about your differential can help give you sort of an organized framework to approach something that, like Claire said, this is weird. This doesn't happen to 39-year-olds. So it's obviously cause for great concern.
Yeah, that's actually Dr. Kearns. That's fantastic. That's actually a great approach. And I agree. I'm usually like an anatomic person and then take a step back and thinking about kind of system based. Once I figure out anatomically what could be the etiology, like what could be causing from a systems based causing at that anatomical region. And Manny, there's been some really great points here. I don't know if you have any other kind of thoughts about this case, like on this history, just from what you've heard so far.
Yeah. No, I think Claire did a really good job of pointing out the weakness that was mentioned. When we think of weakness, it's either kind of this subjective feeling of overall weakness, which is like termed asthenia, and patients will often use that word. But I think what we're usually looking for is there a focal neuromuscular deficit that we need to hone in on? And it sounds like from the history, we've been able to do that so far and kind of localize to certain joints and into his lower extremities. I think what I'd be interested to find out would be, has he been compliant with his anticoagulation? If not, is this just progression of his DVT? The other thing is, was there any workup or was there any provocating factors that led to his diagnosis of the DVT? Might be a little helpful in us kind of teasing things out. I'm struggling to put together the acute liver injury. Saw Dr. Albert mentioned maybe his medications he was taking for the pain may have kind of led to that, but maybe we'll be able to tie this in together a little bit better in the next few minutes here.
Yeah, and that's great points, Manny. And I think you're doing what you should be doing, a kind of higher level thinking about, did they have actually, you know, if anybody comes in with a DVT, was there any explanatory reason for it? And they actually did. They said, you know, because of his pain for the past 3 weeks, he has for past 2 weeks, he's pretty much been bedbound. And so they say that was probably the provoking factor that caused that DVT. It's just because of his immobility. And then Dr. Albert.
I was just going to say that may be the cause, but when you're considering an inflammatory arthritis, don't forget about antiphospholipid antibody syndrome as a cause as well.
Yeah, actually, I was about to give you a shout out for that, because that's a fantastic point. That somebody who's coming in with a DVT and has possible signs of a synovitis or inflammatory arthritis, thinking about like antiphospholipid and or like overlap with lupus. These are all great things to think about. So cool. Well, this is a great starting point. So I'll go into a little bit more detail about him. So in his past medical history, he does have PTSD, depression, and chronic low back pain. Past surgical history, he has had an appendectomy and a right cubital tunnel release. Family history, melanoma in his dad and no problems in his mom. The only meds that he's currently taking are tramadol and atorvastatin. And then notable social history, which we'll see how much this helps, denies the alcohol, tobacco use, or recreational drug use. He was a sniper while he was in the Army, and currently he's a beekeeper and a bartender. So now I know y'all are probably all expanding your differential to see what bee-related illnesses can be causing this kind of presentation. So I'll let you guys dig deep into that one. But any other kind of clarifications for all of our discussants about any of his past medical history, or anything that you would specifically ask him?
No, I mean, I think with the, the elevated LFTs, it's important that it sounds like he doesn't have a significant alcohol history.
Mm-hmm.
Certainly, I think that could explain it in a 39-year-old, but just because he says he doesn't, I tend to trust my patients, but, trust but verify. I'd also be curious to know more about the low back pain and the history around that, just in the setting of like this polyarthropathy, a little bit more of a history of how long he's had that, how it's been treated is, again, like, is it kind of the history we talked about before, worse in the morning kind of a thing?
Yeah, no, that's Claire. That's a great point. And why are you kind of honing in on this low back pain in this gentleman?
Just kind of thinking about ankylosing spondylitis in like a young man with polyarthropathy, and concern for like inflammatory disorder. Yeah,
and so kind of if you were wondering if this is like inflammatory back pain versus like degenerative back pain, kind of what kind of questions would you be using to kind of clarify between the two?
I mean, again, I think I would, is it there when you wake up? Is it better or worse with activity? Kind of like what makes it better or worse? How long he's had it? Has he had a back injury in the past? Sort of like, I'd probably ask more about like, I don't know how much like lifting and stuff he does as a bartender and beekeeper. Like, does he have a story that could explain, like low back pain in a young man or not?
Yeah, no, Claire, that's a great point. And I will say this too, and because in room clinic I have seen like a 36-year-old Army vet who actually was diagnosed with chronic low back pain, and lo and behold ended up being ankylosing spondylitis. And so I think one of the key things to kind of hone on in is that you did a great job about is of all the autoimmune diseases, ankylosing spondylitis A, number one, is like the one that's most prevalent in men. And then for predominantly for your autoimmune diseases, especially these that are the seronegative spondyloarthropathies are going to be like usually in your younger patients. So, or just autoimmune diseases in general, thinking of them in your younger patients. And like you said, chronic low back pain in a young guy is kind of odd. That's not something you typically see, even like, unless he had some like really like great story for an injury, possibly while he was in the Army. And so kind of when you look back through his chart, he said he's just had back pain for like 5-10 years. Doesn't have any like inciting event, just was told it was from like lifting heavy goods while he was in the Army, but otherwise no other kind of inciting issue that was kind of brought that up. So if nobody has any kind of other questions, we can
go ahead,
man.
Question there, Corey. So 2 quick things. Has he been bitten, or does he get bitten regularly? Would be one question as far as the bees. And then was he deployed to like any exotic places when he was a sniper in the Army?
Yeah, great questions. So he was, I think, in Afghanistan. And then he occasionally gets bee stings, but nothing like chronically. What if you don't mind me asking, what are you kind of thinking about with those two things?
No. So I think when we think of these kind of a polyarticular presentation, maybe a little less likely an infectious etiology. We can think about some autoimmune things and things like that, but just common things being common if he's had exposure to kind of some more rare infectious pathogens, or if he's kind of often being bitten and has entry portals through those bee stings. That would be another thing that I would think about as a possible etiology. And in full disclosure, I Googled beekeeper and arthropathy, and there is a thing called beekeeper's arthropathy. So just kind of an interesting tidbit there.
Oh, that's awesome. I'm totally gonna go read about this after I get done with it. No, these are great questions. I think that's fantastic. You guys are all thinking of the good things. And then Jacob Welch actually had a great the Google Journal message. Jacob Welch had a great point, sexual history, thinking about gonorrhea. His sexual history, he's actually been with the same female partner for over a year now.
The only other thing I had is, it sounds like he lives in Colorado. Has he always lived there? Has he taken a few trips to, I'm specifically thinking about places where there are ticks, but
nice.
Other, I think just recent travel history as well to other parts of the country.
Yeah, no, that's a great question. So he was stationed over in the East Coast somewhere. I'm not 100% sure where, but he was not in the North Pacific. And Claire, great, you're thinking great things. What are you thinking about specifically with that?
I was thinking Lyme. I went to med school in Wisconsin, where we see it a lot, and we don't really out here, but people can travel and get that. I'm trying to think if like any of the other like tick-borne illnesses cause arthropathy, and nothing is coming to mind. But I think also like if he could have been exposed to like endemic like fungal infections as well.
Nice. And Jordan is just like a man of puns over there, so I appreciate that, Jordan. And one other thing I'd like to just interject in there, and thank Dr. Urra for asking about the travel history and particularly deployment. So it's an important thing to ask veterans, as there are a variety of known deployment-related illnesses. Most of them that come to mind are pulmonary in nature, and a lot of these things we're just learning about now or recently. So just because it's not known doesn't mean it's not a thing that we'll discover. I think of lung-related issues, and I think of exposure-related issues. I can't, off the top of my head, I can't think of anything that would cause a diffuse arthropathy, but it's always it can be a critical thing to ask veterans. Yeah, and I think the other thing too that we kind of leave out, that Claire made a great point about, is like even just taking out like deployment areas, like even things where they were in training. Like if somebody was on the East Coast, somebody in stationed over in like Fort Bragg in North Carolina, somebody could easily have like picked up some kind of like tick-borne illness there, or somebody might have been stationed up in the New England area and think about Lyme disease. So great question. So we'll go ahead and let's move on to like his vitals and physicals. So on his vitals, his heart rate is 106. blood pressure is 121/80. He had a Tmax of 98.1, respiratory rate 18, and he's satting 96% on room air. And pretty much the notable things on his physical exam, he has like this flat affect, doesn't look like he's in significant distress, or he's not in any acute distress. His neck was normal, HENT was normal, cardiovascular exam was tachycardic, but otherwise normal. His pulmonary exam was clear to auscultation bilaterally. His belly exam didn't have any tenderness to palpation, and it was non-distended. And then on his kind of his MSK exam, so they noted that they actually did a decent neuro like strength exam on him, and they noted that he had 4 to 5 strength in right upper extremity bicep flexion, 5 to 5 in left upper extremity, symmetric bilateral lower extremity, symmetric bilateral lower extremity strength of 4 to 5, but seemed to be limited by pain. And then also noted he had limited strength in bilateral first toes, ankles, knees, which was also seemed to be limited by pain. 2+ reflexes, and then of note from the RAC note, not in the HNP, he was noted to have mild swelling in bilateral ankles. So Manny, CJ, or CJ, I'll kind of kick it to you first. Does any of this kind of help you out?
I think it is helpful. I mean, I think overall he's not in any acute distress. He's afebrile, which I think kind of points away from like a septic arthritis, especially with how many joints seem to be involved. So that's my first thoughts with the vitals and the exam. And then I think the strength exam, even though it's only 4 out of 5, I think that's significant in someone who's 39. I think in someone who's like 88 or something, then they might be a little weak, but it's hard to tell if that's just their age or not. But someone who's feels weak and they're young, I think that's definitely a significant finding. They don't mention like a skin exam or like hand exam or like joint exam if there's any clear effusions, but that would be kind of my next question, and trying to think about what could tie all this together. I'm wondering if he has like muscle tenderness that would suggest a myositis, which could be the cause of his LFT elevation. And then just getting a better sense of the joints and sensing if this is like a really consistent, like an inflammatory polyarthritis where I'd expect a bit of an effusion or at least like swelling. I can't remember if there was swelling in the joints.
Yeah, so he had some mild swelling and kind of bilateral ankles, and they were tender to palpation as well.
Yeah, so that's probably where I'd try to get more skin exam and thinking like down the inflammatory autoimmune pathway right now based on his age and everything I'm seeing. And like, is this like an anti-synthase syndrome or something like that that would potentially tie all this together? But I think we still need more information in labs to kind of further evaluate that.
Yeah, and actually, I think, and I was about to say, Dr. Albert pointed that out too, about his heart rate being 106. And I think that is one of the things, like even if he is not in acute distress, somebody, a young man, have a 39-year-old who was a previously healthy guy coming in with a heart rate of 106 is definitely something to be concerned about as well. And then, and also I think he also talks about if he could have developed a PE, which is fantastic. Good. These are all great things to be thinking about. And then Jordan, kind of answering your question, there weren't any rashes documented, and he did not have it. He denied any GI symptoms. And then Dr. Heppy, I'll let you kind of, I think I know what you're talking about with this, but if you want to kind of elaborate what you're thinking about with pain in the joint with passive versus active range of motion.
Yeah, thanks. Sure, Corey. So, you have the question is there something intra-articular occurring, or is it peri-articular? And so we have the question of is he a myositis? Is it the DVT that's causing all this ankle pain, or is there an intra-articular process, or potentially both? And so one of the things that can kind of help you clarify that, particularly around it's helpful around a single joint. In this case, I'm thinking the ankle is the test if they have pain with active versus passive range of motion, right? So if they have a periarticular process, then they will likely have pain with active range of motion as they're using that joint, but they will not necessarily have pain with passive range of motion. So if you passively move that joint and the joint's still painful, then that suggests an intra-articular process of some form. Can be particularly helpful when trying to differentiate like I think of it being more useful in oligoarthritis or articular pain, but certainly could apply to this instance as well.
Yeah, thank you. That's actually exactly what I was. And I think the other thing to kind of take note, especially when you have a large joint like your knee, and if somebody has decreased range of motion or decreased passive range of motion in their knee and it's like swollen red hot, you should put septic arthritis should be like the first thing in your differential until proven otherwise. So definitely that's one thing to definitely keep in mind if anybody comes in with a red hot swollen joint that they can't move. You should be concerned about septic arthritis kind of first and foremost. So I will go ahead and present the his basic labs and just see if you guys want anything else to gather, any other labs after you get these labs. So I will just talk about, so his BMP is relatively normal. His CBC, he's got a little bit of an anemia of, hemoglobin's 12 and the hemoglobin's 12 and this white count is 9.5. I apologize, I got that backwards. And then his LFTs, he's got a mildly elevated AST and ALT and ALK phos with a normal T-billy. And then he's got a total protein of 8.5 and albumin of 2.4. So I'll kick it back to my discussants. If anybody like anything with these labs abnormal that sticks out to you the most, or what are your thoughts?
Yeah, I think our protein gap there is pretty significant. So it's something that we need to kind of bring to the forefront here and think about. I think the other thing is inflammatory markers I know are not very specific, but might be a little bit helpful here to kind of see if there's something sky high, might help us out a little bit. So I'd be curious to see if we have that. I think, when you have kind of a polyarticular presentation, you think about things like lupus. We don't see any obvious cytopenias. You think about things that could be like a hemochromatosis kind of picture, something like that. He doesn't have any outright evidence of synthetic dysfunction looking at his platelets, but I would probably get a little bit more, I'd get an INR and things like that as well. But I think my big input is just we should talk and think a little bit more about that protein gap.
Yeah, no, that's great. So Manny, I'm going to push you a little bit more. So when you mentioned a protein gap, kind of what's your rule on what is the protein gap and kind of what's your thought process whenever you see elevated protein gap?
So usually if we see a difference between the total protein and the albumin greater than 4, then we should think about that there's something else that's kind of occupying those values. And the big things that I think about are going to be 2 infections, so HIV and Hep C. And then you think about kind of any type of gammopathy, whether it's polyclonal or monoclonal is something you can figure out. And so something like an infection could give you kind of a polyclonal presentation, but I would be more worried about kind of a monoclonal issue if depending kind of what we see on our SPEP, UPEP, and kind of our workup for that.
Nice. Yeah. And actually, you made an incredibly great point on this whole matter is that, whenever you do see, you just put, which I appreciate, you put HIV, HCV, the 2 big things we always think about. Other things like gammopathy, which I know you're putting in there, like multiple myeloma. And I think what Dr. Albert actually pointed out too is that some people don't quite realize at times is that albumin is really like in a reverse acute phase reactant. And so when people have chronic inflammatory states, their albumin actually goes down. In the same vein, like your ESR and CRP are going to be going up. So him having like an albumin that's low is also concerning that he's got some kind of chronic inflammatory state. And Mike putting the great stuff on differential, thinking about Behçet's disease, stuff like that. So I heard you wanted to get some inflammatory markers. I'm going to kick this back to CJ. Is there any, like, if you had to choose one lab or lab image, whatever you want, what would you choose next? Actually, I'll give you 2. You get 2, CJ.
I'm getting labs. I think I would want a CK just to see if this LFT elevation is related to muscle potentially or from the liver. And then I think ESR or CRP could be helpful, although I'd expect it to be high already. And then X-rays of a joint might be helpful as well.
Nice. All right, I'll squeeze that into 2. I'll make room for it because Manny said ESR CRP, and then Claire, I'll see you're admitting this patient. What are your thoughts about, like, what would you get on him?
Yeah, I mean, in just like in general, thinking about the labs, sort of what was highest on my differential was like, with this inflammation, like autoimmune versus a more like indolent infection giving that time course. And I'm leaning a little bit more towards like autoimmune, just to kind of generally his labs sort of look like he's got chronic inflammation and the white count isn't super high. But if I were admitting him, in terms of like serum labs, totally agree with what you guys said. So far, I would probably get HIV and like hepatitis labs. I would get a UA. I would probably get a GC as well. I like the X-ray idea. I'm sort of thinking about getting rheumatologic labs, things like, starting with, like an ANA. But I think I might wait to see what his X-rays show, and wait to get like a little bit more information before like pulling the trigger on that. Yeah.
Claire, that's great. You and CJ and Manny are just like crushing this whole thing. It's kind of I'm actually very impressed with y'all right now. So well done on everybody's part. So what I'll do is I'll read off all the labs that we kind of like as the way they came in, and I'll go from there kind of as you have them listed too. So CK ended up his CK was normal. He had a HIV that was negative. HCV is pending. He had an ESR and CRP. ESR was greater than 100 with a reference less than 13. And then he also had a CRP that was 85 with a reference less than 3. And then he had a UA that was stone cold clean. And then his GNC, GNC's pending right now. So CJ, you asked for the X-ray of the joint. What joint do you want to get at this moment?
I think probably the one that's most impacted, which it sounds like it was one of the ankles, I guess, would be one of the first ones I would get. If his hands were involved at all, I think the hands are always a good room choice, but it sounds like they were not involved in his case.
Yep. Handos are a window to the soul. Danny, you couldn't have spoken any better, more truer words in my life. So they did get an X-ray of his left ankle, and his left ankle actually showed there was no fracture, but possible joint effusion. So you're admitting this guy. What would kind of be your next step while you have these other labs pending at this moment? And I guess why don't we take a step back and kind of think about what exactly, and actually I'll kind of kick this to Manny. What would be your problem representation of this patient, like your problem representative statement of this patient?
Yeah. So 39-year-old male with recent diagnosis DVT, presenting with progressive subacute on chronic worsening lower extremity pain with articular involvement in multiple joints.
Nice. And if I'm gonna press you a little bit more, and I'll see if I'll kick this to Claire and CJ as well. So what if you guys had to say what kind of because it sounds like you guys are thinking this is an inflammatory arthritis. What kind of do you guys have, like, I guess, like buckets you put your inflammatory arthritis in?
Yeah, I guess the things I think about are joint involvement, so monoarticular or polyarticular. So we said it's polyarticular. I think also acute versus subacute versus chronic is important. I would put his, I guess, in a subacute bucket. I think we haven't, CJ kind of pointed out the septic joint, but I think, I think it's important to distinguish that, like, we're not dealing with like an acute monoarticular arthritis, where we would, you know, be like more, we might be acting with a little bit more urgency.
Yeah, no, these are guys, y'all are saying incredibly great points, and I appreciate that. This is fantastic. And so, so the only other teaching point I'd want to add on there is just when you kind of go through your inflammatory arthritis, the only one to kind of think about is an oligoarticular, which is just, it kind of narrows your differential just a little bit more. And really the only thing, it's just polyarticular, except it's only like 2 to 4 joints. And you know, oligoarticular arthritis can totally be a polyarthritis that's just presenting early and just involving a couple joints, but it just kind of helps out with your differential a little bit more. So great. So Dr. Albert also put a SI joints and spine. I'll kind of let Dr. Albert kind of explain that, because that's a great thought and was actually ordered for this patient.
He's got a history of chronic low back pain. You're looking for ankylosing spondylitis. So that'd be the way to look for it. He doesn't need his whole spine image, but certainly the lower part where his back is. You might see calcification of the anterior spinous ligament in ankylosing spondylitis, and the SI joints could be inflamed that you could see on a regular film.
Yeah, no, that's perfect. Thank you, Dr. Albert. And actually, to be honest, the other thing that to kind of help kind of group this, kind of tie everything together as well, ankylosing spondylitis is in the same class as like other ankylosing spondylitis. Doesn't even just it doesn't only present with axial spine involvement, it also presents with peripheral spine involvement. And so this patient also having peripheral, what sounds like peripheral inflammatory arthritis, can totally be also presentation with ankylosing spondylitis. So while you guys are just sitting around discussing this patient, one of his labs actually does come back, and his urine GNC does come back positive for chlamydia. And so, Claire, since you ordered this, what are your thoughts about this one now?
So I guess the big thing I think about for like an infectious arthritis is gonorrhea. Now I'm like racking I think I would have to look up if we can see that with chlamydia as well, because like gonorrhea is a big one. Certainly in a male, it sounds like he's asymptomatic. Men can, you know, have asymptomatic chlamydia, but I would probably look up to see if this could be explained by chlamydia, because I'm drawing a blank on that one. If it was gonorrhea, I would be more excited. But yeah, I'm just drawing a blank.
Manny, I see the wheels turning. What's going on?
No, I mean, I agree. I think acutely, I definitely think gonorrhea a little bit more. I think you can get a reactive arthritis from chlamydia, and so that would be a consideration. He's had this kind of without being diagnosed for who knows how long. So that was kind of the big thing that jumped to mind.
Yeah, and actually, yeah, go ahead, CJ.
I was going to ask, is the gonorrhea negative, or it's just not back yet? Because I know these often come in pairs, so I'm wondering if it's just not turned back positive.
No, great question. So his gonorrhea actually comes back negative. And so the rest of his labs that all come back is he ends up having a negative hep C. His uric acid ended up being 3.5. And then he had a negative ANA, negative rheumatoid factor, negative Lyme antibody. And he actually had an anti-CCP that actually was negative as well. And Rheum ended up being consulted, and he had a positive HLA B27. So what ended up being the diagnosis of this case is he actually ended up having reactive arthritis secondary to chlamydia infection. And so what I was going to do is I was going to, so Sneha, you actually put up a great thing. So you're thinking about, so that's classically in the what we used to call Reiter's syndrome, but reactive arthritis, what is actually doesn't actually present, doesn't always present like that. Danny, I don't know if you can stop sharing your screen. I'll share my screen now. Thank you.
While you're doing that, the only other thing that came to mind is it doesn't sound like based on his sexual history, he would be necessarily be high risk, but if he's got an STD, I'll make sure we sent syphilis as well.
Yeah, fantastic. You're absolutely right. I completely agree with you. This gentleman, he ended up getting checked for syphilis, and that all came back negative as well. But great point. Even somebody having contracting an STI you should definitely check them for the full panel of STD. So kind of what is the definition of reactive arthritis? It actually has like two key components, which I really didn't realize until I was doing a little bit more research in this. It was kind of one of these, it was almost like this nebulous thing. You thought it was just like, oh, it was a secondary to one of these usual infections. But really, actually, the definition is it's an interval ranging from days to weeks between a antecedent infection and then followed by this arthritis. And then these patients classically actually present with a mono or oligoarticular pattern of arthritis that usually involves the lower extremities. And sometimes they actually will present with dactylitis and enthesitis. And actually, when Room got consulted, they actually said one of his toes that he was complaining about actually was dactylitis and not just like an inflammatory arthritis. And so what are the most common pathogens? The most common pathogens actually are chlamydia, Yersinia, Salmonella, Shigella, Campylobacter, and then C. diff and E. coli are now kind of being added to the spectrum. And I looked it up, and actually chlamydia on some papers actually can be up to 8% of cases of chlamydia can develop a reactive arthritis, which was fascinating to me. It was like 3 to 8%, which was way higher than I was anticipating. And then what's kind of the initial treatment of this? It actually, you obviously treat the underlying cause. So you actually will treat these patients. He got treated with azithromycin 1 gram. And then you also treat them kind of symptomatically with NSAIDs. And if they're actually refractory to NSAIDs, you actually place these patients on steroids. And then they can actually develop a chronic reactive arthritis. And at that point, you're actually going to start them on DMARDs. And so does anybody know what this condition is that's associated with reactive arthritis? Because I think it's got one of the most fascinating names, and that's why, and I find it to be incredibly interesting. Yeah, this is a tough one, but this is actually where you almost have like this hyperkeratosis of your of the soles of your feet as well as the palms of your hands, and it's actually called keratoderma blennoragicum, and it's also something that you can see with reactive arthritis itself. And then so this patient himself, so he actually was given the 1 gram of azithromycin for one-time dose for his chlamydia. Also got started on prednisone 40 milligrams with a great response and actually began to be tapered on the outpatient side, but was still having symptoms. So was actually started on methotrexate for a steroid sparing agent. Unfortunately, he actually developed avascular necrosis of his right femoral head about 14 months later while he was still on his prednisone and had to get a total hip arthroplasty. So kind of what I wanted to talk about with everybody is I wanted to kind of also go into kind of how to make your buckets for an inflammatory arthritis. And so really there's 3 buckets we think about: the monoarticular, the oligoarticular, and polyarticular, which everyone did a great job about. And kind of what do you think about with monoarticular? So the big ones are like the crystal arthropathy, so gout, pseudogout. Think also about seronegative spondyloarthritis, infectious, and infectious includes even Lyme also included same spectrum. And then inflammatory arthritis, that for purpose reasons looks like a inflammatory response, but really it's just from an inflammatory osteoarthritis. And then the other one to think about is like heme arthrosis. And then when you think about oligoarticular, every single one of the monoarticular causes of arthritis can be put into that oligoarticular. The other things to think about are like early RA and early lupus that is presenting just with a few joints involved. And the big one that is considered separate from the seronegative spondyloarthritis is the reactive arthritis. What about polyarticular? So polyarticular is kind of all the other stuff that we classically talk about, but think about rheumatoid arthritis, lupus, viral, and seronegative spondyloarthritis, which Jordan so astutely put as kind of is all lumped in with that parapneumonic that all of y'all were taught in med school, where you have psoriatic arthritis, ankylosing spondylitis, and inflammatory bowel disease associated arthritis. So all those are lumped in that seronegative spondyloarthritis. And then going with kind of what one other thing to just kind of point out is I'm a huge proponent of if you have any question about If this is an inflammatory swelling of a joint, or is this like an infectious swelling of the joint, always the best thing that's ever been told to me is tissue is the issue. And if you can, try to sample some fluid from there so you can differentiate between a non-inflammatory and inflammatory infectious etiology. And so these are usually the cutoffs that we classically think about with neutrophils and the synovial fluid. The other thing that I actually just found out, I found out too from Up to Date. So the likelihood ratio actually for synovial fluid PMNs for aseptic arthritis. So when you have the cutoff greater than 25,000, greater than 50,000, and greater than 100,000, the positive likelihood ratio increases from 2.9 to 7.7 to 28 respectively. And so if anybody has consulted ortho for concern for septic arthritis from a synovial fluid joint, sometimes they're not even very impressed with over 50,000 PMNs. And so they'll even make the cutoff, they'll sometimes make the cutoff even like closer to 100,000. But in a clinical context, if the patient is appears septic and they have an inflamed joint and they have over 50,000 PMNs, your clinical suspicion's high enough, it still is considered a septic arthritis. And then the other kind of things I wanted to talk about was one that we don't really get a whole lot of. We hear about all the side effects of corticosteroids, but we really don't really kind of learn like the long-term complications. And this gentleman, he actually had one of the long-term complications with his avascular necrosis of his right hip. And this was a paper that I found, and it actually, to be honest, when I reviewed the paper, it actually didn't give a lot of good definition about, did not give a great definition about how long these patients were on or what dosage of steroids they were on, but it just kind of talked about the chronicity of the effects of chronicity of steroids and their effect. And what it did find is that these patients, over 30% of them had hypertension, but about 21 to 30% of them actually developed a bone fracture, which I think is really astounding. And so I think it's one of these things that when we see patients on chronic steroid therapy, just be cognizant of these things. And if you're able to try to wean these patients off of their steroid therapies, obviously with your consultants at hand. But it is one of these things that I know we sometimes can just know the side effects, but these side effects can have long-term effects. So one of these things to just be really cognizant of. And then Chelsea, you put on there one's associated with HLA. Yeah, and so this is one that actually boarding this. Yeah, so Chelsea, this is actually a great question. And actually, I actually got asked it on our board exam like preparation, and apparently it actually is not indicated to check an HLA-B27. You'd be hard pressed and probably not to find a rheumatologist that will check an HLA-B27, because apparently reactive arthritis, I think it said, is like associated, like 50% of the case, 25 to 50% of the cases are associated with HLA-B27. And I think the utility for this patient is with his chronic low back pain that Dr. Albert pointed out, is that was there concern for sacroiliitis as well. And of note, just kind of on his time course, he actually did not have what appeared to be sacroiliitis. And so his chronic back pain actually probably was from wear and tear. That was initially thought. So, and then Alana, yeah, so this is kind of a, yeah, so Jordan, you're thinking about the kind of our cutoff for like when we start PJP. Honestly, like even chronic steroid therapies, I'll see what Dr. Kearns or Dr. Albert, what y'all's thoughts are, because you guys I know y'all will be prescribing long-term steroids pretty or quasi frequently, I guess, or y'all do it sometimes.
Well, I mean, there's no question that aseptic necrosis is a complication of long-term steroids. Can also see it with trauma, irrespective of steroids. I mean, the point is, you don't use the steroids unless you have to, and if you have to, you use the lowest dose you can, and you do steroid-sparing agents. I mean, it sounds like Room did, they tried, they got him on methotrexate. You could question, if this was due to chlamydia, you could question whether he really needed long-term steroids for this. It should have gotten better after the chlamydia was treated. I don't associate it with short-term steroids at all. I don't know exactly the distinction between long-term and short-term, but a couple of weeks, a month of steroids shouldn't cause aseptic necrosis in my experience. I haven't seen data on that though. It's
Yeah.
really a long-term effect.
No,
There was
yeah,
an,
right, Dr. Green.
just to build off what Dr. Albert said, there was a very nice paper in Annals, I think in the last of internal medicine in the last 6 months, looking at people that got short courses of steroids. So for 1 week or less than 2 weeks, looking at complications and what was most likely to come up. And as I recall, it was episodes of GI bleeding, increased risks of sepsis, as Dr. Albert alluded to. I don't recall that there was any orthopedic fractures or avascular.
They should have gotten some hyperglycemia, I think.
For sure.
Yeah.
And I think that's the big thing. And like y'all are saying, these are people that are patients that are on months on steroids, and even the dosage actually can be. And I guess the point to make is it's not even just 20 milligrams. This is 5 milligrams or 7.5 milligrams. One of my attendings, rheumatology attendings at the VA, he would say even 5 milligrams of prednisone is enough to melt your bones. So, and then Manny, the positive chlamydia with signs of inflammatory or oligoarthritis was enough to actually diagnose this patient with reactive arthritis. So, and kind of to Dr. Albert's point as well, you're right. He did have a prolonged course, and he actually ended up getting reinfected with chlamydia, and so he actually got treated with the Zithro as well. So it probably restarted his his reactive arthritis once he got reinfected. So, yeah. And Claire, great question. I remember we actually did talk with him and her, and she went to her primary care to go get treated. So from our knowledge, she did get treated from our knowledge. Yeah. Well, perfect. Thank you so much for all our discussions. Thank you so much to our experts here who also were very informative and gave us some great teaching points as well. I am going to leave the rest of this to Ellie and the rest of the team. So if anybody has any questions, feel free to reach out to me or anybody else. But thank you everybody for y'all's participation.
Great, thank you, Corey. That was a wonderful case, and thank you to everyone who participated and all the expert input. Okay. Wonderful. Just as some of the residents hop off, Yasmin, are you on? Let me just see. Sorry, we have a lot of people.
I am here, Katie. Hi.
Hi, Yasmin. Hi, how's it going?
It's good. It's good. Good morning or good afternoon, wherever we are in this day. And I want to say hello and welcome to our applicants for today. I'm Yasmin Sakharov. I'm